antigen-antibody interaction. I don't know who is antigen and who is antibody. And Sanket and Avinash are on stage.
Yeah, I think we'll continue the fun break here. So this is very important concept, and again, like I discussed from very starting, that what we are doing here is we are just taking one perspective and moving on into immunity, but we have to have that curiosity for sure that what we are doing. So the moment antigen antibody comes, what comes into your mind? That they are opposite to each other. The plan is to kill, right? That is the thing. But actual thing, all the processes are done by this pair together as a complementary to each other. And as correctly we can see Avinash and Sanket. And let me tell a story behind that. I was his intern when he was postgraduate in medicine. So that pair actually started there. And after that we did, I think, quiz together, and he guided me for so many things. And that's how even the next few slides are the combined effect of antigen antibody sitting in a room together and making the PPT in the morning. Okay. So that's the first perspective we have to change, that together it is a unit. And you will actually see specifically the region of antibody to which antigen binds is complementary determining region, CDR. So they're working together in that part, right? So it's the first thing we start with this. And this is a very basic question, that where does the antigen bind? A, B, C, D. Because I think up to 12th science, I used to think it's B. Right? It's A. I know it's too simple. But sometimes we have to see those parts also. It's not that in between cleft where there is a binding. There are two parts in that Y or the antibody, what we see. And we will go now in more detail also, but this is just the part it comes. Okay. So before we go to this topic, we should have some question in mind, whether we will be able to answer that or whether we'll be able to find answer to that once we complete this, because Google is always there with you, right? So antibody and immunoglobulin, these are the same terms, or is there some difference in that? That what do you find it, right? We have to have this because we use it interchangeably, immunoglobulin and antibody. So what may be the difference there? If an antigen comes for the first time into the body, is there any antibody readily available, or it is going to take time to develop that antibody? Why you need so much of antibodies when you already have so many cells to attack, right? It's again going to that analogy of the war. You have so many soldiers, but you need many bullets because you want to kill so many, right? So that is a kind of thing which goes there. Can you name few diseases you think are antibody mediated? Or can you think few diseases where it happens because antibodies are deficient or dysfunctional? Again, we have to have our thought process very broad. In HIV, you see hypergammaglobulinemia. In multiple myeloma, you see hypergammaglobulinemia. The number is high, still you are susceptible to infection. That's a very important thing to develop. I know it's very simple, but we have to keep that in mind, that this is not we talk on the quantity here. It's a function we keep talking throughout. So let me introduce this very simple concept of this binding. Now see what the antigen-antibody binding will make it little more precise. The antigen, what is in a way shown here in the blue, will express many of this epitope. And one antigen can express many epitope also. So that is the epitope part of the antigen to which the antibody binds. And in that antibody, the part which is binding is a paratope. So it's a binding of epitope and paratope, which is the first step to have, right? And again, the diagram of antibody is not that great. We will come to that. But it is just giving, we have different kind of antibodies, and see it's a kind of, one kind of paratope can be carried by different classes also. Like you have IgA or IgG and IgM to the same part, and That's what the class switching sometime what we say that it was IgM, but now we need more, so IgG class switching is happening, and it is getting more precise even in the attack. So we'll see the structure, types, and source of this antigen and antibody, and then how they interact and what happens once they interact. This is the first 10 minutes I think I'll try to occupy, and then Avinash will be giving more of a clinical implication of what we have discussed. Okay, so this we can now see antigen and epitopes located in dot. So antigens are nothing but a molecule, moiety, foreign particulate, or a matter, or an allergen, which can bind to specific antibody or T cell receptor. Now see, again I want to give a little break here. The T cell receptor is a part which we have to actually keep in mind. Because whenever we were learning type of hypersensitivity, type 1, 2, 3, 4, right? 1, IgE, fine, makes sense. 2, immune complex makes sense on a location. 3, circulating immune complex makes sense. And 4, suddenly we are, no, it's a T cell mediated immunity, right? But that also makes sense because the interaction is with antigen, which is truly defined. So it is in the right thing, but our context should be perfect, then it will make sense. It can be either protein, peptide, polysaccharides, lipid, or nucleic acids, and the source can be either exogenous or the self. We are now aware of the terms like PAMP or DAMP. We cannot generalize PAMP or DAMP exactly to the antigen, but yeah, it can be from either outside or inside damage. The immune system has to sense everything, right? So these are the few terms to know. I just want right now to imagine that what comes to your mind when you listen to endogenous antigen or the exogenous antigen, super antigen, autoantigen, neoantigen, tumor antigen, and tolerogen. Now all this antigen has to be communicated to this TCR, BCR, or the antibodies which are there. For that, you have professional presenting cell, which is predominantly your dendritic cell, macrophage, and B cell. But the other cells, nucleated cell, which has MHC1, also are there to present, and even we can induce MHT, MHC2 in presence of certain cytokines. So everything can present the problem when it is available. Okay, so the endogenous is more on location where the antigen presentation is happening. Okay, that we'll be discussing with MHC part. Super antigen, toxic shock syndrome, we have seen it bypass the MHC path and directly stimulate cell in the hyper part. Autoantigen, autoimmunity, we can correlate. Neoantigen is very important thing which happens in tumor immunology. That suddenly the body is seeing something for which we are not ready at all. Okay, so the tumor control which was achieved, it gets lost. And then you have tolerogen, which we use for the immunotherapy. So this is the exact structure of antibody, how it looks like. But it's not conventional for any of us to learn from this. We are trained like this, that this is what something, if you show me, I'll try to understand the parts here. Okay, so let's focus on what we are seeing exactly. So we have this light chain, one more light chain here. Okay, the two light chain. Light chain has one variable and one constant region. The same thing is happening with the heavy chain. Let's follow this. Okay, so there are 3 constant domain and 1 variable domain. And again, the same story here. So if you see this side, totally from above the hinge region, this is the antigen binding site, which has 2 places here. Okay. Now, why there is a hinge here? Because we want to be flexible and catch that antigen, right? So these are simple things we should have, keep thinking why those things exist, and then if something is a problem there, can a disease happen, can the antibody function matter, right? If someone is planning to engineer the antibody, all these things matter or not, right? So that's the hinge region there, what you can see. And here is the part where the antigen binding is going to happen, right? So one here and one there. Now, if you really see the antigen or the epitopes located on antigen, this is the paratope part. So on a surface, if there are 2 antigens which are located, and this antibody directly can have that binding there. If you have IgM, which is a pentamer, the 5 things together, you can actually clump it up, right? So that everything decides on how the things are going to go ahead. Now we see about the Fab part. So each has this variable domain, and 1, 2, 3, 4 variable domain, 2 from light chain, 2 from heavy chain you are getting. And each variable domain has 3 hypervariable region where the binding happens. And that is what it determines the idiotype. to a specific organism, it binds, that specificity is achieved at idiotypic level, which is different at, even in human, these antibodies differ at these sites. Now, the again very important point, when we were discussing about PRR PAMP, we don't discuss this but specificity. This is the characteristic of the adaptive immunity or the things what we are discussing this. It folds to make the loop of beta strand, and which is called the CDR, complementary determining region, nothing to do with complement system which was discussed recently. Okay. And 3 CDRs from each of the heavy and light chain will mix the antigen binding site, and this gives the flexibility in the shape and size of antigen to be bound. Okay, so this is very basic, but it is very important to imagine that how many things the immune system has to deal, which can come in various size and shape, and it has to be that specific, that level. So the epitope, if we understand better, if we understand our gun or the bullets better, then the things hit very properly, right? So now this has identified something, but the message has to go down. And then this is the Fc region what we discuss here. Fc decide the isotype of the antibody, and you have IgG, IgA, IgM, IgD, and IgE. Few are in the monomeric form, specifically IgD, E, and G, while the IgA can be the dimeric form, while the pentamer is this. I think Avinash is going to discuss, but I have one question. Right now, inside your body, if we see in the total quantity, which is the antibody highest in the total amount? IgG, IgA, IgM, IgD, IgE. There should be one answer to that. Keep it in your mind, it will come sometime, right? Fine, so this is what the Fc region does. It conveys the message which result in action. Okay, so it has to bind to some receptor to do the action. These are the Fc receptor which comes, okay. This is how the antibodies look, right? This is Ig, and then you have variation to that. This is IgM monomeric form. You have a pentameric form there. So you can imagine that here like kind of 10 things you can catch it together. So once we are catching this part, the reaction is happening, right? So the antigen-antibody reaction, what happens is non-covalent bond. It's a marriage. There's a possibility of separation, okay, because it's non-covalent bond. Fine. So the hydrogen bond, ionic bond, hydrophilic, and van der Waals which attack. But now again, very important thing. Now it is not antigen-antibody. We are in the mode of epitope-paratope, right? We know that now this is things what is happening. So one antigen has many epitopes. Now an interaction of antibody paratope to the epitope at an individual level, how tight the interaction is there? It is affinity. But with multiple paratope, how this multiple epitopes, how all this antibody or the paratopes are binding, the combined thing is avidity. So this is the most important difference to remember between affinity and avidity part. The consequences of this binding can be either a neutralization, or the agglutination, or the precipitation, or the complement system activation. We already learned that complement pathway gets activated through that. Or the phagocytosis that PRR were recognizing, and it goes inflammation and the cell lysis. There can be many consequences which happens. But how that happens? This is one example of Fc gamma, right? You have a pathogen which is bound to the antibody. Again, we go in this Y circle, right? This is how we are trained. Okay, so this is otherwise, okay, we can now be little more, one epitope, paratope was caught here, one was caught here. And after that, through this Y or the Fc receptor, it communicates to cell. And previous whatever was happening, many can think be mediated through this part, right? So now you have, again, I think this was discussed by Dr. Shakir, and I'm using it, fine. So that you have ITIM and ITAM, right? So there are certain parts which are inhibitory, specifically with the Fc gamma R2b, which is CD32b, and other are stimulatory or the activating receptors, which are giving signals to the downstream cells. Fine. So I'll keep up to this. The next application part will be discussed by Avinash.
So you will see that we have, tried keeping it simple, because the detailed version, how these antibodies are being formed, how the class switching occurs, how that specificity comes is going to come later. And as Sanket mentioned, सुबह इतना ही बन पाना था, तो we could only make this much in the morning. So this is how simple I have made it, as against the interferons that we had discussed in the morning. Some case-based scenarios we will see what is the utilities of these antibodies, the monoclonal antibodies which have come, what subtypes they are, how have they derived their nomenclature, and we will finish off with mechanisms by which IVIG acts. So a 28-year female, not so newly married, visits a gynecologist after that rainy night, LMP 8 weeks ago, and gynec orders that torch panel, and you have IgG CMV positive, right? The reason why I'm bringing up these cases is because in the next few slides, we will see the different properties of these subtypes. So what do you do if the IgG CMV is positive in this young female who has just conceived? We will start treatment, we will wait, repeat test, do CMV by PCR, or we will order other enzymes and see if we need to treat. Students, if you would like to take this up. बहुत इजी है, यहाँ पूछ रहे हैं इसका मतलब ये नहीं है डिफिकल्ट कुछ कॉम्प्लिकेटेड आंसर होगा, स्ट्रेट फॉरवर्ड नहीं. अच्छा, विल यू ट्रीट और नॉट ट्रीट? नॉट ट्रीट फॉर द सिंपल रीजन it's IgG antibodies, right? Another female, joint pain, anemia, WBC count slightly on the lower side. You have total protein and albumin being mentioned there, with total protein being 7.8 and albumin 3.5. The significance here is high globulins. So high globulins, they give us a clue, because what are globulins? These are basically the antibodies, sum total of all the antibodies. A very simple and a cheap way to figure out if we are dealing with some maybe chronic infection or antibody mediated disease or an immune complex mediated disease. Because we all know that they might be increased in these set of diseases, chronic infection, B-cell mediated disease like lupus, even chronic parasite infections. They might be increased in paraproteinemias, myelomas. Drugs like sulfasalazine can cause hypergamma-globulinaemia. And rarely they could be a part of inborn error of immunity, the new name for PIDs, like hyper-IgM syndrome, they might be increased. So the globulins will give you a clue that probably you are looking at something happening maybe at the B-cell level, but we need to figure out what is contributing to those globulins, right? On the other spectrum, it might be decreased, like in cases of primary immunodeficiency diseases, drugs, or it might be a clue to an infection. For example, in setting of lupus, you might get an infection with CMV because they have persistently, say, low globulins. So let's try focusing on these antibodies one by one. We have 3-4 case scenarios here. A kid or an adult male, 5 days history of fever, cytopenia, myalgia. Another kid, 3 days. Another history of 2 months history of fever, backache, exposure to cattle, and 15-month history of backache with MRI suggestive of spondylitis. So in first case, what will you order? What are you thinking of? Some viral infection maybe, right? So here the importance will be of an IgM antibody. Whereas if the history is very short, like 3 days, even the IgM antibody might not have appeared. So that's why we look for antigen there, right? I think I know it's pretty simple, but it's just for discussion's sake, learning from the antigen and antibody. Some mistakes that we do is some patients who come with 8 months history of polyarthritis had fever at onset, we order chikungunya, IgG is positive. But we tend to forget to look at rheumatoid arthritis because IgG positivity does not mean it's an active infection, right? However, if you are dealing with cases like brucella, you have the exposure history to cattle exposure is there. Patients are coming with as PUO, they have backache. So if it's a long history, the IgG becomes important there provided you do a serial titer. You have to show an increase in the IgG over time. So these tests have some diagnostic and misdiagnostic utilities. Misdiagnosis is if it is not interpreted in proper context. In acute cases, you would think about IgM. IgG would tell you it's a chronic infection. And if it is chronic active, you will show a persistently rise in the IgG titers. That is the diagnostic utility of these antibodies. And we also talk about, I think you all are well versed of this. At least the persistence of antibodies needs to be shown in antiphospholipid antibody syndrome. Why is it important? Because some infections can cause positive IgM antibodies. Unless they persist for 12 weeks or more, you cannot call it APS in a proper clinical context. The only exception being CAPS, where you give a cutoff of 6 weeks. So this is what I actually wanted to come to, looking at these. Yes. So how do you used to remember which is, so the question that Sanket had asked, which is the most abundant antibody in the human body? A. How many for A? 1, 2, 3, 4. And how many for IgG? So the question was in the body. It was not, the question was not in the serum, right? So in the serum, it is IgG. Most of the questions that were asked is because they were asked in serum. So in serum, yes, I agree. The IgG is the most abundant, but the most abundant, like it was mentioned in the morning, what we have is the lymphoid tissue, which is there everywhere, mucosa associated. There's lots of IgA also there. So total amount, it is IgA, but in the serum, it is IgG. So I used to remember it like this when it comes to, the percentage, the amount of antibodies and half-life. I used to use a mnemonic GAMDE, G-A-M-D-E, G has the highest highest quantity as far as the serum is concerned, and half-life. This is also very important. Why half-life is important? If I say the IgG has a half-life of 23 days, how does it apply clinically to you? One is we saw the antibodies, the diagnostic utility. Have you used IVIG? Right? Have you used it in patients who are immunodeficient? So when do you repeat? 1 month, right? Because the half-life is around 3 to 4 weeks. So that is when you would want to know. So that is why it is important to understand some simple properties. The complicated properties will come later, but the simple properties of these antibodies. The half-life. The shortest half-life is probably for IgE. And again, what is more important is you need to understand the complement binding. This is also very important. Which of these antibodies are activating classical pathway? The IgG and IgM are more pertinent when it comes to activating the classical pathway, and IgA is implicated in alternate pathway. And it is this property which is being used in synthesizing these monoclonal antibodies, keeping these things in mind. So we all have read about hypersensitivity reactions. There are 4 types: type 1, type 2, type 3, type 4. Again, most of them are antibody mediated. Type 1 is mediated by IgE, results in classical allergy. Do you know of any antibodies which act against IgE? Or are there something called as IgE antibodies which are being given to the patients? So omalizumab is what? IgE. Anti-IgE. But which IG? कौन सा immunoglobulin है वो? It's IgG, right? So why IgG? Why not IgE? Longer half-life, right? So that's an IgG antibody against IgE, omalizumab. Then we have type 2, which is IgM and IgG mediated, type 3, which is immune complex mediated, and serum sickness. These are some important examples of hypersensitivity reactions which are mediated by antibodies. IgE, how does it mediate allergy? It goes and binds to the Fc receptor meant for IgE, which are present on the mast cells, causes degranulation, and that's how it mediates type 1 hypersensitivity reaction. Now we will just quickly go through understanding of these different types of immunoglobulins. This is not working, so I will come directly to this. I think you all are aware of different subtypes of IgG, right? Because of the IgG4 disease, we all know that there are various subtypes. Now, which one of this fixes complements in a most potent way among the 4 subtypes? And why it is important to know? इसको क्लिनिकली कैसे अप्लाई किया? So heard of rituximab? Rituximab is what? IG, G against CD20. Which IgG it is? उसमें 3 है, 1 है, 2 है, 4 है. 1. So it has 3 in the highest amount. Basically, it's majorly 3 because 3 has the property to fix complements most avidly as compared to the other subclass. And this is the difference in all the 4 subtypes. If you look at IgG3, like Sanket was mentioning, we need to be flexible. जितने flexible होंगे adjust होंगे, right? नहीं तो life is difficult. Similarly, IgG3 has, if you look at this, it has 4 hinge regions as compared to other IgG subclasses. IgG1 has 2. Then there are differences in the sulfide bonds, and this is how, this gives them slightly different properties. IgG1, G2, G3 with 3 followed by 1 has the maximum ability to fix complements. This is what I was talking about. Ability to activate classical complement pathway is maximum with IgG3 followed by IgG1. And if you look at percentage of total IgG, it is IgG1 which is highest in the sera, followed by IgG2 and IgG3 and IgG4. And they also have different, these antibodies have response to different kind of antigens. We talked about antigen and antibody, but what type of antigen it is, it determines what kind of IgG subclass is going to get more activated. For example, for proteins, it is IgG1 and IgG3 and IgG4. But for polysaccharides, IgG2 is more important. Similarly, they have different, Fc gamma receptor binding. There are differences in that. For example, IgG2 only binds to Fc gamma receptor 2 as against IgG1 and IG3, which can bind to all 3 Fc gamma receptors. And this is just a diagram, showing how from birth till adult, the levels, they begin to change, and the highest level of IgG1 is achieved over 10 to 14 years. So these are again applied aspects, trying to understand where they can be low. For example, in CVID, the IgG and Ig or IgM can be low. Generally, most commonly it is the IgG1 subtype which is low in CVID, less than 2 standard deviation. In A gamma globulinemia, the total IgG will be less than 100. Then there are IgG subclass deficiencies. That's also very important. It's not that uncommon. It's just that we miss it because the total amount of IgG that you will order might come out to be normal. But if you have patients who are showing sinopulmonary infections, recurrent infections, there are definitions for that, and the total IgG is still coming out to be normal. But if the index of suspicion is high, you need to order the subclasses. And the most common is IgG2 and IgG3 subclass deficiency. Similarly, on the other end of the spectrum, we have high IgG4, which is seen in IgG4 related diseases, rheumatoid arthritis, Loeffler's, because IgG4 is implicated with allergy. So that's why we know that in IgG4 phenotypes, there is a phenotype where there is more of allergic symptoms. What is Loeffler syndrome? Heard of it? I can't hear anything. Yes, because it is 2 Ascaris, right? So now let's move on to some more applied aspects, the concept of monoclonal antibodies, and thanks to these 2 scientists that the principle of production of monoclonal antibodies was understood, and it has totally changed the scenario. From understanding the pathogenesis to the application has completely changed with the availability of these antibodies. So these are the methods by which we name them. If you have an XI in the antibody, I think all of you must be aware, but we will just revise. Let's revise together. If there is an XI, it means there is a chimeric antibody, like infliximab. What is XI? Why it is chimeric? Because you can see there is a portion which is derived from mouse. Then if there is ZU, it means it has been humanized. Humanized, like for example, certolizumab, which means predominantly it is the human fragment which is there. That's another way of, understanding the same thing. If this red color is actually depicting mouse, as the human component in the antibodies increase, they are referred to as humanized. This is fully human. Here, a portion of the hypervariable region is derived from murine, so it is called as humanized, and hence the term Zumab. But when it is fully human, it is called as UMAB, UMAB, right? Now, keeping these things in mind, now I told you about rituximab, right? Rituximab is IgG3 antibodies against at least against CD20. Now, tell me, why does rituximab does not work in all patients who have B cell, in wherever B cell depletion is being done? What is the success rate in rheumatoid arthritis or lupus for that matter? Or in other words, why was the need for bringing another molecule called as obinutuzumab? What is the difference? So for that we need to understand how rituximab works. So if you look at rituximab, there is something called as direct cell killing, which is called as DCD. There is something called as ADCC, which is antibody dependent, and then there is something called as a mechanism by which through complement it mediates. Like Sanket was asking, if there are, say, in lupus, why it has not met with good success? The complements are already exhausted, low. So maybe this mechanism is not really working well there. Or there are already antibodies against complement, which will not allow rituximab to act. So keeping these things in mind, because of that background knowledge of how the rituximab was working, they came up with obinutuzumab. In obinutuzumab, what they did was, they said, this doesn't seem really important, right? So let's focus more on ADCC. Let's improve antibody-dependent cytotoxic killing. So they engineered it in such a way that the ADCC was much more as compared to complement killing. And how did they achieve that? Something called as? Anyone? Yeah. So that is how they achieved it. This improved the ADCC. And it also took care of, in subset of patients. Now this is theory, right? That is how they are designing. In those subset of patients who may have antibodies against complement, it might even work in these subset of patients. So that is why if we have the knowledge of the antibody structures, how they are functioning. Sorry? How did they? Glycosylation. Fucosylation, glycosylation, that's what they did. And this Pankti is going to discuss, I think. If we are aware when these antibodies, how they are getting rearranged, when these receptors are being expressed, we can think about targeting these cells. Now the last slide is IVIG. How many of you know how does IVIG work? Yeah, how was IVIG derived? It's there, it's from the pooled plasma, because all of us have antibodies against so many infections, even antibodies against, so the plasma was pooled and that's how IVIG was prepared. But what the paradox is, in patients who actually have this was actually prepared in 1950 for those who had immunodeficiency. But the amount of IVIG which is needed for patients who are immunodeficient vis-a-vis patients who have autoimmunity, there is a huge difference in dosing. Can you tell me why? And can we use IVIG in sepsis, or do we use IVIG in sepsis? So you have to think of the answers to these questions. Tell the answers to Sakir in the lunch. And if you don't have answers, Sakir will tell after the lunch. So that he doesn't. एक ही सवाल का जवाब देने में मजा नहीं आएगा, right? So this is how IVIG acts. This is the last slide. This is how IVIG works. It's not as simple, antibody de diya, kaam khatam, right? It works on multiple levels. Let us start from here. We looked at the receptors, right? Fc gamma receptors were there. So there are various types of Fc gamma receptors, 1, 2, 2b. 2b is inhibitory because it has downstream molecule item. There is Fc gamma neonatal receptors. So what IVIG does is, it starts competing with the immune complexes. It starts competing with the cytokines. It competes with the antibodies which were already present. Why? Because it may have anti-idiotype antibodies. It will go and attack the antibodies which were pathogenic in that particular individual. So it is going to act at multiple levels, antibody levels, cytokine levels. It is going to change T cell plasticity, more Tregs will be formed. It acts on the B cells. It increases B cell apoptosis. It stimulates the inhibitory Fc gamma receptor 2b, causes neutralization of B cell survival factors. It competes with the immune complex so that it can go and bind to the B cell receptors and T cell receptors and does not allow the B and T cell to get activated. What it also does is it competes with the other antibodies which are present in the blood by going and binding to Fc gamma neonatal receptors. Now these are important for clearance of antibodies. So if it goes and occupies those receptors, the antibodies which are present, they get cleared very fast. So these are the multiple mechanisms by which IVIG acts. It acts also on the innate system, decreasing the T cell mediated T cell activation, decreases pro, increases anti-inflammatory cytokines, decreases DC differentiation. Some of the mechanisms are not clearly understood. So it's not as simple as that. It's just not, a cocktail of antibody, put it inside and it mops up everything just through one pathway. There are multiple pathways being implicated. So I'll wind up with this. Sanket always loves movies. So he said border se shuru kiya tha. So this movie is actually based on the anti-diphtheria toxin, right? Which was how it was discovered and how it was used. So, thank you.
So
Let's call Sanket on the floor.
You have already answered the question before lunch.
I've already answered?
You showed that IVIG.
Yeah.
Basically, what I think is that when we don't know the right answer, we'll put up so many options. You can pick the one you like most.
Right.
So anyone has any questions?
Or you can answer those questions. Is there role of IVIG in sepsis?
How many of you think there is a role of IVIG in sepsis? Show of hands. Does it reduce?
अब तो शिनॉय सर ने हाथ खड़े कर दिए, बाकी भी कर सकते हैं. So I think there are a lot of trials. The logic says yes, it should work. It's an antibody that we are giving. But then it also hinders the natural antibody response which the body is trying to mount, right? Because it will mop away the other antibodies which the cell is making. It is going to affect the T cell and the B cell response which the body is going to mount against these foreign antigens. So that's why it did not really meet with that much success, and it's no one really, हम लोग कभी ऐसा करते हैं कि इन्फेक्शन आया, एंटीबॉडी भी दे दिया, IVIG भी लगा दिया, सेप्टिक शॉक में जा रहा है, IVIG लगा दो. We have not been doing that because that's what happens in immunology. We think that, okay, we have now completely understood this pathway and we have cracked it, but
one way of thinking about it is we are giving maybe 80 grams of IVIG, but out of that 80 grams, what percentage is actually going against that particular infection? Because 99.9% will be non-specific for that infection. Even
Right.
if you are giving such a high load, practically very small percentage is going to interact or inhibit the bacteria which is causing the sepsis. And the bacterial load is already very high by the time patient is in sepsis.
Right.
So many RCTs have been done, but no one has shown success.
the other challenge is targeting the phase of infection, when to give. Have you missed the bus? People have also used, there's something called as pentaglobin, which is very rich in IgM, unlike IVIG, which is IgG rich. I don't know if someone has an experience of.
For example, everything in the infection, every time, most of the time, depends on when are we giving. In COVID, we have seen, because in
Yes.
early the antibody works. Later on, in dengue, same thing. If you give those people who have antibody, they have worse. So we are not sure, it is not a lot of gray zones, it's not black and white, how this antibody, viral antibody, and antibacterial antibody, antibacteriophages, all these things we need to learn lots and lots. We are just beginning to learn. Thank you, Sandeep. Sepsis with mass.
Sepsis with mass. I think people have used, but not very encouraging data as if I can recall. We have been using it in patients who have had mass in background of autoimmune disease, but again, it's not the drug of choice there.
But always, everybody will agree that when there's an infection in setting of autoimmune disease, lupus
Then
or
we
something,
use,
definitely IVIG is our,
It's a safer option.
yeah.
Sir, does IVIG also cause any change in the glucocorticoid responsiveness? Like we see that IVIG is preferred in patients who show glucocorticoid resistance. So I recently remember reading somewhere that in patients who have glucocorticoid resistance, there is increased expression of the inactivating type of receptor at the nucleus level. But IVIG causes a change in that phenotype, where there is more of increase of the activating type of receptor, where it also increases the glucocorticoid responsiveness when we give IVIG along with steroids in a patient whom you are planning for some immunosuppression.
So I think you have already answered it.
No, I wanted to add on to the
I had no idea
points.
about this.
No, I
So
wanted
thank you
to
for
just add
questioning
on.
and following
I just
it up with the
wanted to add
answer.
on to the slide what you had put in the end.
I have no idea regarding that.
Fantastic. So, thank you, and thank you, Avinash and Sanket,